Good morning everyone. Today we are going to learn about squamous cell carcinoma, basal cell carcinoma and malignant melanoma. So first we will discuss about squamous cell carcinoma. So coming to introduction, as the name itself says, squamous cell carcinoma arises from squamous epithelium. It is the second most common tumor arising on sun-exposed sites. It is usually seen in older people and males are more commonly affected than females except on lower legs. Coming to causes of squamous cell carcinoma, DNA damage due to UV exposure, like in case of xeroderma pigmentosum. So what is xeroderma pigmentosum? It is a rare inherited genetic disorder which makes the skin and eyes of the patient extremely sensitive to UV radiation. Then second is immunosuppression, like in case of post chemotherapy, post organ transplantation, etc. Then industrial carcinogens like tars and oils, chronic ulcers, chronic draining osteomyelitis, old burn scars like Marjolin's ulcer. What is Marjolin's ulcer? It is a cutaneous malignancy arising in the setting of a previously injured skin. Then ionizing radiations or in oral cavity, tobacco and betel nut chewing, and HPV infection or human papillomavirus infection. Sites or most common sites of squamous cell carcinoma: skin and mucous membranes lined by squamous epithelium. Most common sites includes face, pinna of ears, back of hands, lips, and it can also be seen in external genitalia, lung, cervix, mucocutaneous junction, oral cavity, respiratory epithelium, esophagus, gallbladder, and urinary bladder as metaplasia from transitional cell lining. So these are the most common sites where you can get squamous cell carcinoma. Coming to the clinical features. So how the lesion will be grossly or clinically. So the lesion will be sharply defined, nodular, hyperkeratotic scale, ulceration, elevated and indurated margins, and fungating and polypoid growth. Coming to the microscopic appearance, there will be irregular downward proliferation of epidermal cells into the dermis. Depending upon the grade of malignancy, the masses of epidermal cells show atypical features. So as you already know, there are certain atypical features the cells show in case of malignancy. So one is variation in the cell size and shape, which is known as pleomorphism. Then nuclear hyperchromatism, individual cell keratinization, occurrence of atypical mitotic figures. So there will be atypical mitotic figures as well as the mitotic figures will also be increased in number. So this is the microscopy of squamous cell carcinoma. So here you can see this is the epidermis and this is the dermis part, and in the dermis you can see plenty of tumor cells of varying size and shape with hyperchromatism. Some of the tumor cells showing hyperchromatic nuclei. This is a group of necrotic tumor cells, and this is the blood vessel, and this layer is the papillary layer of the dermis, and this is the epidermis. And these are some keratin pearls. So keratin pearls are typical microscopic features of squamous cell carcinoma. So based upon the keratin pearl, the presence, how much keratin pearl is present and not, the histological types of squamous cell carcinoma are of 3 types. So keratin pearl, it is actually a keratinized structure formed by abnormal squamous cells placed in concentric layers with increase in keratinization towards the central area. So coming to the histologic types, based on the histological pattern, 3 types are there. One is well differentiated type. So there 75% or more keratin pearl will be seen. Then second is moderately differentiated. There 50 to 75% keratin pearl will be seen. Third is poorly differentiated, where there will be 20 to 25% keratin pearls only. So these are the keratin pearls. You can see the concentrically placed keratinization. So this is the picture of well differentiated squamous cell carcinoma. This is moderately differentiated and this is poorly differentiated. And these are the keratin pearls. So that was about squamous cell carcinoma. Next, coming to basal cell carcinoma. So basal cell carcinoma is the most common invasive cancer in humans in sun-exposed areas. It arises from basal cells of interfollicular epidermis and or hair follicles. It derives its name from the cytologic similarity of tumor cells to that of the normal basal cells of the epidermis. Because of that resemblance, it is known as basal cell carcinoma. It is slow growing and it rarely metastasizes, and the most common site includes hairy skin, and the most common location in 90% of cases being the face, and that too usually above a line from the lobe of the ear to corner of the mouth. Less than 0.5% are locally aggressive and disfiguring. So this is the picture of basal cell carcinoma, and another name for this is rodent ulcer. So why the name rodent ulcer? Because it erodes the underlying structures like a rodent. Coming to the predisposing factors. So light-skinned people who have little amount of melanin are more prone. Then prolonged exposure to strong sunlight, inherited defect in DNA repair mechanism in xeroderma pigmentosa, then PTCH1 gene deletion, then nevoid basal cell carcinoma syndrome. So what is it? It is a autosomal dominant condition in which multiple basal cell carcinomas appear at a very young age, that is under 20 years. And the clinical features includes, usually it presents as pearly papules containing prominent dilated subepidermal blood vessels, which is known as telangiectasia, and it may present as erythematous plaque. Advanced lesions may ulcerate and cause extensive local invasion of bone and facial sinuses, then nodular lesions, and as I told you, ulcerative rodent ulcer. So this is the gross appearance. So grossly, as you can see, ulcer is nodular, ulcerative with the rolled out margins. Coming to microscopy of BCC or basal cell carcinoma, it arises from the epidermis and do not occur on the mucosal surfaces. Tumor cells resemble those in normal basal cell layer of the epidermis. So as I have told you earlier, that is why it is known as basal cell carcinoma. Cells have hyperchromatic nuclei, which means darkly stained nuclei, and scant basophilic cytoplasm. And the tumor cells are arranged in clusters which are separated by stroma. The cells at the periphery of the tumor cell islands tend to be arranged radially. So that pattern of arrangement is known as palisading pattern. The stroma retracts away, creating clefts or separation artifacts, which is also another typical feature of basal cell carcinoma. So this is a diagrammatic representation. So here you can see these are the tumor cells or basaloid cells, and here you can see one gap. This is the shrinkage artifact, and this is the solid pattern, and this arrangement of cells, tumor cells, is known as palisading pattern or palisading arrangement. So basically palisading arrangement is single layer of cells arranged, as you can see here, single layer of cells arranged perpendicular to the surface and parallel to each other, and the stroma retracts away, creating clefts or separation artifacts. So this is the palisading arrangement, and this is the cleft or shrinkage artifact or separation artifact. So this is the actual microscopic picture of basal cell carcinoma. So here you can see tumor cells arranged in nests, and at the periphery you can see peripheral palisading pattern, and here you can make out due to the shrinkage there is a clefting or shrinkage artifact, a small space. And these are all the tumor cells arranged in nests and islands. Next, coming to malignant melanoma. So as the name itself says, malignant melanoma is a tumor arising from melanocytes. It is one of the most rapidly spreading malignant tumor of the skin that can occur at any ages or all ages. The etiology is unknown. Role of excessive exposure of white skin to sunlight, example, higher incidence in New Zealand and Australia where the sun exposure is high. Then due to mutation in certain genes like RB gene, P10 gene and CDKN2A gene. So the CDKN2A gene is a tumor suppressor gene. RB gene is also a tumor suppressor gene. Then PTEN gene is another tumor suppressor gene. So it is a most deadly skin cancer due to exposure to sun. Other sites includes oral cavity, anogenital mucosal surface, esophagus, meninges, eyes, sole and palms. Clinical features. The most important clinical sign is a change in the color or size of a pigmented lesion. The main clinical warning signs are as follows. 1. Rapid enlargement of a pre-existing pigmented skin lesion, itching or pain in a lesion, development of a new pigmented lesion during adult life. 4. Irregularity of the borders of a pigmented lesion. And 5. Variegation of color within a pigmented lesion. So this is the gross appearance. So gross appearance, to remember the gross appearance of malignant melanoma, there is a mnemonic that is ABCD. A is for asymmetry. The lesion will be asymmetric. B is for borders irregular. That means the borders of the lesions will be irregularly shaped. Then C for color. The lesion will have variegated appearance or variegated colors. Variegated means different shades or different colors. Then D for diameter increased. That means the diameter, if it is increased, as I told you earlier, change in size or shape of the lesion. So that is the mnemonic to remember the gross features of malignant melanoma A, B, C, D. Asymmetry, borders irregular, color and diameter increased. This is another picture of malignant melanoma gross appearance. Coming to microscopy, marked junctional activity can be seen at the epidermodermal junction and it grows downwards to the dermis. Tumor cells are usually epithelioid or spindle shaped and the tumor cells are larger than normal in size compared to the normal melanocytes and will be arranged in masses, sheets and islands. They have large pleomorphic nuclei with conspicuous nucleoli. Mitotic figures are often present and the tumor cells arranged in various patterns such as solid masses, sheets, islands, alveoli, etc. Melanin pigment may be present. If present, it is known as melanotic melanoma, or if absent, it is known as amelanotic melanoma without any prognostic influence. Then two growth phases can be seen: radial growth pattern and vertical growth pattern. Radial growth pattern is the initial stage. So here melanoma spreads horizontally and it does not have any capacity to metastasize. Vertical occurs after the radial phase and there in this phase they grow vertically downwards into deeper dermis, and in case of vertical growth the risk of metastasis is very high. So this is the picture of malignant melanoma. You can see the tumor cells, melanocytic tumor cells with hyperchromatic nuclei, nuclear pleomorphism arranged in nests, coats, sheets, etc. So this is actually, can you tell me which phase this is? This is actually vertical growth phase. Okay, that is after radial phase. As you can see, it is going vertically downward, deeper into the dermis. So this is actually a vertical growth phase.